panel of researchers include Sharon Gilliard, an anthropology grad student at UNC Charlotte, researching the health disparities of black women in Charlotte. Jalen Cole, a UNC dual graduate student as well in public health and medical anthropology. Her research areas of interest include women and children's health and also epidemiology. And Nigel M. Grant, UNC Charlotte dual graduate student as well in public health and biomedical anthropology. Her research degrees will cover the health equity, women veterans, and structural violence. Let's talk about women's health equity, and I'd like for each of you ladies to tell us a little bit about your approach to this topic, and I'll start with Sharon.
Of course. So with the Women's Health Equity Institute, and also in conjunction with UNC Charlotte, with us being students, is to make sure that we're working collaboratively with the community. And this is extremely important because when we're going into this, we want to make sure that in the focus groups that are being implemented, that the women's voices are being heard. Each woman has a story to tell. And with the story that's being told is very important to understand each individual experience. Understanding these experiences, how we as the researchers will be able to connect what the disparities are, be able to have a clearer distinction of what we can do to contribute to help with any type of solutions or resolutions that we can come up with. So part of that too is understanding, what the intersectionality of each woman is. Understanding that allows for us to also look at the data that's being presented. Looking at the data from that point helps us to come up with other ways and avenues of other tools that could be offered.
Jalen, for you and being involved in this research project, and your area of specificity also is epidemiology, talk to me about your decision to be a part of this particular research area.
I think for me it was more personable. Just about 10 years ago, I had a really bad traumatic experience after going into labor with my second child. And so just as a child, I always said I wanted to be a doctor to help people, right? And so, going through that traumatic experience, it kind of just like lit a fire up under my feet. And I said, you know what, there's more than one way to help people. You don't have, more than doctors can help people. And so I just started looking at ways that I could navigate how can I help people and how can I be an assistance to other people, especially other black and brown little girls who look like me, who got pregnant at a young age, who didn't know how to advocate for themselves, and then had very, traumatic experiences. So for me, it was my experience of navigating that healthcare system and not being heard and not knowing how to advocate for myself that just lit this passion in me. And so as a graduate student, whenever I was given the opportunity to work with the WHEI and help start this initiative, I was ecstatic. I was excited. I was like, yes, this is what I've been waiting on. It was like a dream come true for me. It was like, the big gift under the Christmas tree.
You come at this from a different angle. Talk with us a little bit about why this Women's Health Initiative crosses the board for women of color.
There's too many times where women in the military, we were treated like the guys. You crack a tooth, well, we're downrange, you fly us into Germany, you fix my tooth, you send me back. But if I'm having issues with female reproductive organs, it's like, just keep her stable till she gets back to the base. And then you get back to the base after a 6 or 12-month deployment, and you're getting a new doctor who's like, let's start from the beginning. And that can happen 2, 3, 4 times in your career. And so for me, my experience was I gave birth to my son, and I was hospitalized while pregnant with him because of something that happened when I was in basic training. So that was when I was 19 to 24. So then I give birth to my son, and I'm having issues that started when he was months old, and then I'm dying at the age of 34 because every doctor has passed me along and is not listening, and I don't have enough blood in my body now. So now I'm passing out. I have to do PT. I had one doctor tell me it's not a health issue, it's a woman's issue. Going forward, I almost lost my life 10 years later because they wouldn't listen to me when my kid was first born. I can't worry about education and a good career when I'm literally trying to figure out shelter, food, and health. So now you have shelter and you have food, but now my health is the issue. Are you getting that new job? Are you able to go to college? Are you able to start finding a mate and building a life together? No, because you're trying to figure out these foundations. And as women, such things as hysteria being in the medical books, because when they don't like how we act, give him hysteria, institutionalize him. That was allowed. And we're not very far from that now. I feel that I have too much not to help other people find what they need. And so I try to make sure that I share my privilege. I don't take it for granted.
I'm going to say something to you ladies, and I want you to think of it in terms of this women's health initiative that you're working on with research. There's an old adage in this country that if white people have a cold, black folk have pneumonia. From a healthcare standpoint, when it comes to our health as women, are black women the ones with pneumonia and about to die? You described something like that for your own life, Nigel. But is that why this research is important? I want each of you to answer that, because black women theoretically got pneumonia when it comes to health right now.
We tend to be a culture of being othered. So when you identify something as being somebody else's problem, the majority will bow out like it's not my problem, it's theirs. Great example of that was when numbers started coming in and we were on lockdown and it started talking about the most people being affected were African American people. A week later they were protesting because they needed haircuts and wanted to be able to go to their bars because it wasn't their problem, it was ours. And so when you look at this, it's easy for them to say, okay, black women are dying, we get it, but we're not the only ones dying. We're the ones dying more often. So if you can figure out ours and decrease our deaths, it's going to trickle down. Because the maternal mortality rate is an issue for all women. Out of all developed nations, we're the worst. We're the most expensive healthcare, we're the most privatized healthcare, and we are the ones who are doing the worst for the last 40 years. And it's not like, oh, we're getting better. We're getting worse at being the worst. So it's important that they realize it might not be your problem because it's us who are dying more often on these tables or in our homes. You're still dying. And your people, your mothers, your sisters, your cousins are still dying. And they might be that one out of how many that pass. So helping us, by default, is going to help everybody.
Sharon, tell me this, what kind of questions do you envision that women need to not only answer for this research, but questions they should raise for themselves?
I think that the questions that should be raised is how to get, equitable health care. What are the resources that are out there for equitable health care? Where can I go? Who can I talk to? Black women in general are considered as a vulnerable population because of the way that the systems are structured. We saw here with COVID recently that proved this, that it proved that there's not equitable resources, that black women do not have equitable health care or access to get to these things. So part of that is advocacy. Who is out there advocating for these women? Who is out there to speak up for these women? Who is out there to provide, guidance? Who is out there that can, trust and provide and lead guidance? Those are some of the things that need to be asked and questioned and put out in the forefront. That's why this work that we're all involved with is extremely important, because it's going to help answer some of these questions. We all plan to delve deep into it, delve deep into the data, listening into what their concerns are, listening to some of the disparities, listening to what their experiences are in this world of health care and maneuvering through spaces. But it all begins with how. Where can I go? So that's part of one of advocacy.
Let me ask you, Jalen, when we're talking about the data, the numbers, and crunching the numbers, how will you put this stuff together so that a layperson will understand what you as a researcher can look at numbers and see immediately?
So I want to go back and use the parallel that you used between the different population sets, one having a cold, one having pneumonia. So, and my girls know I'm known for being devil's advocate, right? So let me start off by saying this. Both subpopulation groups started out with a cold. Neither one was different than the other. The only thing about it is, because of some of the data out there, because of some of the research out there, this majority population group, which I would identify as my white population, they had better access to health care. They had the health insurance. They had transportation back and forth to the doctors. So because they had those type of resources, it lowers their numbers and their chances for that cold to develop into something else, whether it's pneumonia, bronchitis, upper respiratory infection, whatever the case may be. They have those resources, so they're able to combat it as soon as possible. Now, on the other hand, our minority populations who maybe have less access to health care, less access to transportation, less access to healthier foods to help combat these colds, right? So what happens is their colds turn into pneumonia. So it starts out the same, but because of the resources that we have, it changes our health outcomes. There's no balance because there's no equitable access, especially within Charlotte. And so it's like, okay, we start off at the same level playing field, but because of the resources and the access that we have, it changes our health outcomes, which drives our data. Those outcomes drives who survives, who don't survive, who has the access, who doesn't have the access, who can get that care and who can't get that care. And so if we don't get to the root of things, and if we don't get to the core and fix some of these systemic and racial issues and these policies and these laws that are actually upholding some of these structures that are creating these inequities, we're always going to be a cold versus pneumonia. So just with that being said, we have to start at the origin, at the root, if we want to see a difference in these numbers and a difference in this data.
The research that you ladies are going to be involved in, compiling all of it, will it include finding out where these possible resources, is there anything that says where the resources are so that women of color know where do I start? Or is this a case of y'all have to figure out where do they start?
Well, right now we're working in conjunction with the undergrad students to build what's called a directory, where they're identifying all different types of services. So whether it's mental health, food, because that's a big part we've heard of talk about several times, transportation, doctors to see, and they even have a table of contents that's going to identify them. They'll have their name, what they provide, how to contact them, and you'll be able to at least have a starting point from there. And so that should relieve some of the pain, because a lot of times the issue is not the event, it's how to resolve the event. And so we're trying to alleviate it by doing that. We're also working on meeting with people in listening sessions. And they're identifying things within their community, as well as identifying what things aren't in their community. And that's a key part, right? Like, so we created this directory, but how much of this is where we need it? And then those things that are, even in doing the research and reviewing this, it shocked us how many things there are.
Sharon, let me ask you this. How are y'all finding the women to talk to? Are there specific age groups that you want to talk with, or is it across the board? Because you got younger women, then you got postmenopausal women. So how are you finding the women that you need, and how do they reach out to you?
Of course, and that's a good question. So what we're doing is we're looking at women with the age group of from all perspectives of life, right? Starting from 18 and up. We want to make sure that we're capturing the whole demographics and throughout a broader perspective to capture the story. Because we understand too that as Black women, that there are specific stages in life where access to health is going to be different, where experiences to health is going to be different, where our lived experiences are going to speak, truth to different things that we've gone through. So that's very important that we capture all demographics and all age groups first and foremost. Secondly, how we're going about this is we're welcoming and we're asking all women to come and join us. And we're doing this by, making ourselves available. We're doing this by going to different areas to ask for them to come to us, getting this out by word of mouth, getting it out by email. We have flyers that have, gone out, but we're putting it out there for all women to join us. This is a community effort. This is something that we want to listen to. This is something that we take serious. And I can speak for all of us to say too that it's a privilege.
Yes.
It is a privilege for all of us to welcome you and to hear your stories and to include that. All the information that we're collecting is going to be given back. I know that earlier you asked about resources. How is that going to look? How is it going to look to get it to the women? Well, I can assure you whatever we find, we're going to give it back, and that will be used as a resource too for these women to use.
I want to ask you about other information that you've gathered that says you don't have to reinvent the wheel because others have got a template. Talk with me a little bit about this California Maternal Quality Care Collaborative, because it says toolkits, and there are things down here that people should be aware of, women should be aware of, and what you should do. There's a cardiovascular disease toolkit and others. So Nigel, talk with us a little bit about that. How does this fit? Does North Carolina or Charlotte specifically need to have these types of ways for women to get assistance?
Okay, so again, we go into the idea that if somebody goes into an ER and says, I think he's having a heart attack, the first thing they do is follow a protocol. They're going to check an EKG, they're going to get you in a room immediately. There's certain steps that they are required to follow based off of that. They don't really have that when it comes to women delivering children or women coming back with issues, right? So when I did go back and say, I'm having these kinds of issues, this is what I'm noticing, these individuals created toolkits to say, okay, if they come in with this, here's the steps that you take to make it happen. So we don't even have to recreate the wheel. We can literally take what they have because it's been proven to work for years and bring it back. It's cut down their rate by 50%. Just by creating a protocol. So now, if I go in, if we all go in and we have 3 different doctors, we're gonna get 3 different treatments. Whereas if you create this protocol, it at least gives them a starting point and a baseline so that their lack of experience in something won't negate the importance of it in my body. And also it ensures that it gives them ideas to think of different things and think of it as in the woman coming in, not the Black woman coming in, not the Asian woman coming in, but the individual coming in. Because they will naturally say, oh, you're pregnant and you're Black, so you gotta have diabetes, right? Oh, it's in your blood. You know what happens with Black people. No, they sit down and would say, well, what is your eating like? Let's discuss that. They don't just assume we're eating chitlins and fried chicken and collard greens with pig feet in it. They're taking the time to individually talk to that person. And so in doing that, it ensures that people are protected, right? Somebody's advocating on their behalf. There's literally a checklist now, which they call a toolbox, that you would use to go down the list. Because sometimes even if you think you know what it is, you should kind of eliminate some things first. Because several issues mirror, or certain issues trigger other things. And those would be more bold and obvious. And if you stop there, you fix this, which was a symptom of this root. And so that's why that's so successful right now. Another one we've been talking about is extending Medicaid from 60 days postpartum to a whole year, because 3/4 of these deaths that women are dealing with, they're dying the last end of the year, right? So if you did have diabetes or hypertension or these things during your pregnancy, you don't just give birth to a baby and your body bounces back in 60 days. These are things that need to be monitored quarterly, annually, monthly, depending on the individual. And so by ensuring a woman has that health care to the end, when she's struggling to make milk and her child's starving, but formula's too expensive, you can go to the doctor and see maybe there's a block and there's something we could do. But if you don't have that because it's day 61, where do you go? So those are two really good things that have been proven to work, and 17 states have not chosen to extend the Medicaid. But if you look at those states, those are the ones who have really bad maternal mortality rates as well.
And among those states is?
North Carolina, yes.
Jenna, let me ask you this. With this program and the research that you ladies are doing, how long will this take to compile this information? Is there an end date on what you're doing, or is there a possibility in doing this research you'll find something else that leads you to another level of research?
I don't think there will ever be an end date. Even for us, this is not something that we just started, right? We are using prior research, prior data, prior numbers, prior experiences to bring that all together to say, what can we do in this community to improve the health outcomes? And there's no one-fit-all solution. For every woman, there's going to be a different need, there's going to be a different experience, there's going to be a different testimony. However, what can we do to impact as many women as we can at one time? And then when we decide that we move on with our careers and with our lives, and after graduation, there is still work to be done. And so what we're doing, we're saying, okay, thanks to the ones who started it, you've passed the baton. We're going to do what we can while we're here, and for however much longer we want to do it. And then when it's time for us to move on, we want to pass the baton to someone else as well. And so it's never ending, right? You don't just reach optimum health and then you're done, right? It's something that you work on daily, yearly, for a lifetime. And then it's something that you teach your offspring to work on. So it's never over with. There's no endpoint. There's no timeline. This work is so valuable that if anyone comes in your space and try to say, we're going to put a timeline on it, kick them out. Kick them out of your space. And I say that humbly, because you cannot put a timeline on this. You cannot put a capsule on this. You cannot put an endpoint on this, because it's forever going. We have to be forever seeking to improve the health outcomes of all women. But we're starting more specifically with the Black women in the community. But this is something that all women would be able to benefit from.
Now, there are 3 women standing in front of you. One's in her early 20s. She's just starting her life. Feels good. Life is wonderful. She's finna take the world. The other's in her 40s. She's raised her children. She's starting to look at menopause. It's coming her way. And the other one, well, she's in her late 60s. Still pretty healthy. But wondering what does she do with the rest of her life, and how does she stay healthy until she leaves? How would each of you convince those 3 women that they should be a part of this research and be on one of these Zoom calls? In your 30-second elevator speech, how do you convince these 3 women from different backgrounds at different levels in their lives that they should be a part of this research? So let me start with you, Sharon.
Of course. Thank you. And that's a great question.
Yeah.
I believe that with the example with the woman in her 20s and then 40s, and then you have an older woman in her 60s, it's very important to understand through a life course framework perspective. We need to understand the individuality with each of the healthcare and access needs. So allowing us to come into the space, and that's why these focus groups are with different age groups, so that we can understand within the demographics and age and what is needed. For us to be in that space and to be able to listen to their stories It solidifies what the needs are. And during those different life course stages, it allows for us to delve in deeper to see exactly what is needed at 20. What do you need at 40? What is at 60? The 20-year-old may not have, that much with going as in with having access to healthcare. They're just getting started off. So insurance is questionable. How do I get insurance? That might be something. The one that is in 40 may have raised kids and might have a little bit more access to financial stability. That might be something. And then as you get older and you are getting into your 60s and 70s, what about transportational needs? What about that fixed income? Now you're maybe living on a fixed income to where you're not able to have access to health. So allowing for us to review that information and look at these different life stages gives us a clearer, distinction between what those disparities are, what type of resources can be provided to each of those age groups, and how to get it to these women. That's what's most important.
How do you approach them, Jalen? I mean, they've got different mindsets, they've got different pockets with coins or no coins. But how do you convince those three women that it's worth their time to talk to you?
My message for each individual would be the exact same. There is nothing new under the sun that someone else has not gone through. We need your voice, and nobody, absolutely nobody, can tell your story the way you can tell your story. And your story has the potential to unlock a plethora of resources, a way to navigate this system, and a way to overcome this system. And so, hey, I didn't even need 30 seconds. That's it for me. It's the same message.
Nigel, you got them, and you got to convince them. They're sitting there going, I don't know if I want to do this. So what do you say to these Black women that says, stop for just a minute and listen to what I've got to say?
Individuals sometimes learn to overcome from our testimonies. And there's certain things that a woman at 60 has experienced that a 20-year-old could never even fathom. And so whether we decide to share a focus group or write it up nicely and you read it, there's certain things that I could tell a 20-year-old woman that could save her life. And there's certain things for the 40-year-old woman that can help her enhance her life, so when she is the 60-year-old woman, the quality of life, and she doesn't outlive her income. And so having these connections allows us to ensure we're covering all the bases, because at the end of the day, our goal is to save lives. And that's what this research would do. Whether you're one of the few women who have a kid at 50 and 40, or a woman who said, I'm never having kids, that was me and my grandma told me to shut up, and you wind up having one in your 20s. Something's going to happen in your life, whether you control it or not, and understanding where you're going will help you understand how to navigate it.
It's the Women's Health Initiative, research that will help all women. And these graduate students at UNC Charlotte are going to lead the charge. Jump on board. You might just learn something.